Thank you for the introduction, Dr. Flanagan. So the presentation today was supposed to be initially on bladder cancer's effect on sexual health in both women and men and infertility. But I didn't realize how much literature there is on just male sexual health. So I'm just going to present on male sexual health. So I'm going to do a very, very brief introduction to bladder cancer, and then we'll go over the impact of bladder cancer itself and its treatment on sexual health in males, and we'll go by treatment, so kind of by stage of bladder cancer. Very brief introduction. So bladder cancer is the fourth most common cancer in men. The average age at diagnosis is about 73 and represents about 4% of cancers in the US. And I'm talking about extent of diagnosis just because I'll talk about treatment a bit after. About half will be less than T2, so non-muscle invasive bladder cancer. About a third will be T2 or T3 at diagnosis, and remaining cases will be T4 plus. And as we see, it's more common in men than women. Here's just a summary slide, including some of the treatments for bladder cancer. So I'll talk about URBT, radical cystectomy. I'll talk about chemotherapy, both intravesical and systemic, immunotherapy, intravesical and systemic, and radiotherapy, and their impact on sexual health. A very brief overview of the relevant anatomy for bladder cancer and its impact on male sexual health. So organs that may be affected when treating bladder cancer are the prostate, seminal vesicles, ejaculatory ducts. And I included just a brief talk on the anatomy of the neurovascular bundles, which are relevant especially for radical cystectomy. So we can divide, depending on the anatomy book, but more or less the neurovascular bundles into three parts. So the posterior neurovascular, I'm not sure if we see my arrow here, but the posterior neurovascular bundle, which I put here in blue. So it's this part here, which runs within the non-villieuse fascia and the pararectal fascia and will innervate the rectum. We have the lateral neurovascular bundle, which is here and supplies the elevator ani. And more relevant for this presentation, the posterior neurovascular bundle and the here and the cavernous nerves, which will supply along the posterolateral surface. When we look at the literature in women, the pelvic floor seems to have, and the disturbance of the pelvic floor seems to have an important influence on sexual health after radical cystectomies, notably. There's not much literature in men, but I think it's safe to hypothesize that it could be a possibility in men as well. Okay, so I'll start on non-muscle invasive bladder cancer. There is, I would say, the literature overall is scarce, but there is a few interesting studies that I'm going to talk about. And then we'll talk about radiotherapy and surgery for muscle invasive bladder cancer. And I'll also talk about treatments for metastatic bladder cancer. So the first one is, it's a lot of studies in this presentation. So the first one is on patients who are under surveillance for bladder cancer. So this study was a cross-sectional survey on 150 patients who were just diagnosed or had recurrent non-muscle invasive bladder cancer. And they participated in an RCT. And I'm just putting the relevant conclusions here, but they found that about 60%, mostly men, were sexually active in the 4 weeks after the diagnosis. Important statistics are that 54% reported some form of sexual dysfunction, which is more than the age and gender match healthy population statistic, which is more between 20 and 45%. I think an important thing that we often don't, at least I don't counsel patients on in my residency, was that a lot of patients are not sexually active because they're afraid to inflict harm on their partner, whether it's just from the diagnosis of bladder cancer or because of intravesical treatments. So 23% of patients with non-muscle invasive bladder cancer were afraid to inflict harm on their partner by sexual contact. Here's another study, which was a mix of a quantitative and a qualitative study, basically with self-reported sexual activity, interest in sex, and physiologic symptoms over the previous 4 weeks of diagnosis. And study one, which was the quantitative study, linked that there was an association between non-muscle invasive bladder cancer and sexual symptoms and relationship issues. Again, about 23% of patients had some worry about contaminating their partners with treatment agents like BCG. Here, I don't think we see much, but basically this is the qualitative part of the study, just telling what patients said about their sexual impact in male and female. If we just look at the most affected patients, so one of the patients said that we don't have sex with his partner because of the stuff they were putting in me, kind of alluding to possible intravesical treatments. And another patient saying that his marriage turned into more of a platonic relationship, just putting some words on the impact that bladder cancer and treatment can have on sexual activity, even in the non-muscle invasive bladder stage. If we just look at a rigid cystoscopy, there is some studies that show that even cystoscopy can have a temporary impact on sexual quality of life and sexual performance. So this is a study of 100 consecutive patients who had diagnosed rigid cystoscopy with some or without interventions at the same time. And they had to fill some forms, and they were looking basically at multiple things, but mostly sexual activity before, immediately after, 2 days, 14 days, and 30 days after cystoscopy. And what we see is that using one of the questionnaires, which is the EDIS, there was a statistically significant worsening of sexual symptoms from before to 2 weeks after rigid cystoscopy, but that difference disappeared after a month. So we can conclude that there is kind of also a temporary effect on sexual function at least 2 weeks after cystoscopy, which seems to return to baseline after a month. If we look at TURBT itself, this study wanted to evaluate the impact of TURBT on many symptoms, including sexual satisfaction and erectile dysfunction in around 250 male patients. And they were measured at 10 days only after surgery. What they found is that if we look at baseline erectile function of patients with bladder cancer without any form of treatment, they already seem to have worse erectile function than the general population. And all of those worsen, obviously, post-op after 10 days. When they kind of comment in their discussion, they mentioned that there might be an age confounder because patients with bladder cancer might be more sick because of their risk factors and are generally older. And they mentioned that the scores of erectile and sexual function seem to be worse in patients who had an extended TURBT, more time of catheterization after, who had some sort of complication, or who had like a dose of chemo after TURBT. And they hypothesized that it might be related to some kind of disruption by the electrocautery with the TURBT. Now, if we look at BCG, I never really, as a resident, gave recommendations for patients, male patients regarding sexual activity after BCG. If we look at like the official patient pamphlets, they usually recommend to abstain from intercourse after BCG from a variable amount of time. Some people recommend 1 day, some people recommend 7 days. There's not a lot of study to kind of support the time that we should recommend patients to abstain from intercourse. This study wanted to evaluate the effect of BCG on erectile function in male patients with non-muscle invasive bladder cancer. They were all relatively healthy patients, around 60-year-old, which were not affected by any metabolic syndrome, comorbidity, or any endocrine thing that could affect erectile function, and none of the patient used any drug for erectile dysfunction at baseline. And they filled many questionnaires, including the IEF-5 questionnaire, during the 3rd or 4th treatment of BCG, and also 30 to 40 days after the 6th installation. And what we find basically is that during treatment, sexual function was worse than at baseline and after BCG treatment, but it seems to go back to normal after BCG withdrawal. So can kind of conclude that men experience ED or sexual dysfunction during BCG, but it gets better after. And The authors seem to hypothesize that it might be related to the LUTs that patients get with BCG, because an IPSS score that was bad was also associated and was found in the study to be an independent predictor of ED. So in many papers, they kind of mentioned that there might be a relationship between the LUTs from BCG and erectile dysfunction from BCG. So counseling is important for these patients. Now, if we look at intravesical chemotherapy, this study was a study from China that looked at whether TURBT and intravesical chemo adjuvant influence sexual function in male patients. So the sexual function was evaluated before and 1.5 years after the initial TURBT, and patients were administered the IIEF questionnaire. And what they found, they kind of divided the patients into two groups as a post hoc analysis. So younger patients less than 45 and older patients more than 45. And what they found is that the incidence of ED post-op was significantly more increased in patients who were younger and who had TURBT and intravesical chemotherapy. So there might be more an impact in those younger patients for this specific treatment. That's another meta-analysis of many studies looking at the impact of intravesical therapy on quality of life in patients with non-muscle invasive bladder cancer. I just put their summary here because otherwise it would be too long. But if we look at intravesical BCG therapy, it seems like, as I mentioned, there is an initial impact which can last mostly during treatment, and that the effect on sexual dysfunction seems to be tied to increased lusts. When looking at long-term, they mentioned that BCG might have maybe some long-term benefit related to urinary and sexual symptoms on more of the long term for patients who are stable with their disease. The studies on specific chemo is very scarce, and there are very case series or single case reports. There is maybe some thought that mitomycin, while it will initially worsen urinary symptoms, may have a more positive impact than other intravesical chemotherapies and compared to BCG. Gemcitabine doesn't seem to be very good in terms of sexual symptoms after. And pirarubicin maybe by extrapolation, if we combine it to hyaluronic acid, was linked to improvement in pelvic symptoms and urinary symptoms, and maybe indirectly they suggested that it might improve sexual health, although not proven. So just a quick summary for non-muscle invasive bladder cancer. Patients at baseline, there seems to be a greater rate of sexual dysfunction if we compare to the general healthy population. About 23% of patients worry about contaminating their partner with either the treatment agents or just the cancer itself. Rigid cystoscopy might have a temporary effect on sexual function. If we look at patients who had TURBT, there might be a relationship with longer surgery, longer urethral catheterization, some complications after surgery, or patients who had a one-dose chemo after surgery, they might have temporarily worse erectile function or sexual function. BCG also has an impact, but it seems to be temporary. Younger patients with TURBT and intravesical chemo might be more affected temporarily. And maybe there is some evidence that mitomycin, compared to other intravesical chemo, may be better in terms of sexual side effects. So still, I mean, there's not a lot of literature for non-muscle invasive bladder cancer, but still, I think it's food for thought, especially when counseling patients, that there might be an impact, especially for BCG. So now for muscle invasive bladder cancer. Was there anyone that wanted to make a comment or heard a noise? Okay. So for radiotherapy, I included some studies, and I will mostly extrapolate from studies from prostate cancer. So this is an early study from 1998, looking at patients who got what they called radical radiotherapy for a muscle invasive bladder cancer between 6 months ago, but less than 5 years ago. Patients were male, less than 75, and in complete remission since their last treatment. And it excluded patients who had a TURP and patients on a hormonal treatment. and they administered a questionnaire that was kind of homemade, looking at, among other things, sexual function, including libido, frequency of sexual activity, erectile function, orgasm, and ejaculation. And patients were asked to answer questions on their sexual activity 6 months prior to the diagnosis being made, and radiotherapy, and at the present time, so between 6 months and 5 years later. And if we look at here, there's different questions that the patients were asked. So I'm not going to go over everything, but for example, graph A is on sexual thoughts or desire. Graph C is on if they had erections, if they were firm enough, etc. And we see that there is basically a stabilization or decrease in sexual function for most questions. So in summary, 72% of patients claim to have had erections that were sufficient for intercourse prior to radiotherapy, but this decreased to 56% following treatment, with a decline in the quality of erections. And the patients also reported a decrease in the frequency of their morning erections, which kind of suggested more than just a psychogenic component, but also an organic component to their erectile issues. If we look at longer term, this is a study that was made in 2002. I'm not sure if there's someone who's unmuted because I hear my voice as an echo. But basically, it's a study made in 2002 looking at patients who had radiotherapy for bladder cancer before 1995. And they compared those patients with patients who had radical cystectomy and some form of diversion, and patients from the general population. And they mostly compare patients who were radiated versus patients who had surgery. And basically, everything seemed to be better for patients who had radiotherapy. So there was lower sexual dissatisfaction in patients who had radiotherapy, with a relative risk of 0.6. Erectile dysfunction was more common in patients who were operated versus patients who had radiation, with a relative risk of 0.8. And when we look at, obviously, loss of ejaculation was more common in the operated men versus radiation men because of the nature of the surgery. This is another study where I'm also talking about radiotherapy. Basically kind of concludes the same thing as the previous study, so I'm not going to go over it. Here is a study which also looked at long-term survivors of muscle-invasive bladder cancer, comparing quality of life in muscle-invasive bladder cancer who had either radical cystectomy or trimodal therapy, so bladder-sparing treatment. And it was a cross-sectional study looking at patients who were diagnosed from 1990 to 2011 and were disease-free for at least 2 years after treatment. And they used several quality of life questionnaires. If we look at only the sexual questionnaires and the answers for these specific questions, what we can conclude is that patients who underwent, male patients who underwent TMT reported fewer difficulties with erection and ejaculation, but they also felt more comfortable being sexually intimate than patients who had radical cystectomy, and they were less concerned about contaminating their partner during sexual contact. I think this is the one last study. Basically, I'm including on patients who had either TURBT plus or minus intravesical treatment versus patients who had radical treatment, so radical cystectomy or radiotherapy plus or minus systemic treatment. And also, the patients were administered similar questionnaires. And what they found is that the rate of sexual activity, as we expect, varied with sex, age, and long-term conditions. So patients who were more sick had worse reported sexual function. And patients who had radical treatment, whether that's surgery or radiotherapy, were less likely to be sexually active, had more erectile ejaculation issues, and more intimacy issues. The study is kind of weird because they grouped together patients who had radical cystectomy and radiotherapy. So because the amount of patients who had radiotherapy was a small sample, so they just grouped everyone together. And there is a lack of baseline data, so it's unclear if the differences are because of differences in baseline sexual function. And the last kind of editorial study that I included on the impact of radiotherapy on bladder cancer, basically the summary is that most studies on the quality of life post radiotherapy for bladder cancer are small studies, retrospective, single center, and some of them use unvalidated questionnaires, kind of homemade questionnaires. Many studies look at only recurrence-free patients, so possibly there is some bias in the reporting of the impact of radiotherapy on sexual health in those patients. If we look kind of at comparing the doses, this I didn't know actually from my residency, but the protocols for muscle-invasive bladder cancer and prostate cancer, what is the radiotherapy, like the doses comparison and the time where the radiotherapy is administered. The doses are pretty similar, as we can see on this slide, and they're usually, although there are different protocols, and some of them are hypofractionated, but they're more or less given around similar period of time when we look at radiotherapy for treatment for muscle-invasive bladder cancer. Radiotherapy can also be used in other settings for bladder cancer, but I'm not talking about that. I'm going to talk, so there's no specific study on how radiotherapy for bladder cancer specifically affects sexual function, but I'm going to talk about basically extrapolating findings from prostate cancer and assuming that the pathophysiology is the same. So most studies that look at radiotherapy after prostate cancer support a vasculogenic etiology, whether that's an arteriogenic etiology or a venogenic dysfunction. So the main study used penile Doppler in patients who had radiotherapy for prostate cancer, and they reported that in 63% of patients, the ED, based on the Doppler ultrasound findings, seemed to be because of arteriogenic etiology, and 33% because it was of a venogenic etiology, and other had either like other causes that could not be seen on penile Doppler ultrasound. Some other studies that support the same finding used other imaging methods like cavernosometry and cavernosography that we don't use very much nowadays. And there's also a study that actually looked at histopathology of patients who had radiotherapy in that area, and they found some damage in the endothelial cells lining arteries, luminal stenosis, and arterial, and they concluded that there was some form of arterial insufficiency for these patients. There is also some studies suggesting potentially a neurogenic pathway for the ED after radiotherapy for prostate cancer. So this was a study by Dr. Carrier looking at basically rats who had radiation therapy in that area, and they found that the number of nitric oxide synthase containing nerve fibers in penile tissue, as well as erectile function that they measured and RAST using intracavernosal pressure, decreased with patients who had higher radiation dose. So possibly also a neurogenic component to ED after radiotherapy for both bladder cancer and prostate cancer. This is the longest part of my presentation, and I think it's, to me at least, it's a most interesting part, but looking at cystectomy and what we can do when we do cystectomies to potentially improve erectile function in patients. So this was my favorite study that was included, but basically it's kind of a descriptive study that looked at how we should report on erectile or sexual function after cystectomies or radical pelvic surgery in general, including radical cystectomies, and what are the flaws that previous studies have and how we can improve reporting those outcomes. It looked at radical prostatectomy, radical cystectomy, and also rectal surgery. So the first part is how we can improve assessment of preoperatively. So the key things that we should include are patient's age, because as we know, it's related to erectile function, patient comorbidities, especially metabolic syndrome, and we should report on pre-op erectile function status, as it is a major predictor for recovery. The assessment methods should include validated tools, like the IIEF questionnaire, as I will talk about later. And the timing of assessment is crucial. Ideally, we should evaluate erectile function before cancer diagnosis, as it may provide more accurate results for comparing before and after. We should describe also the surgical approach. I'll talk a lot about that in the next slides, but robotic versus open and other nerve-sparing techniques should be reported when we do these studies. Surgeon experience may have an impact in both functional outcomes and oncological outcomes, including EF recovery, erectile function recovery. And we should also report on specifics of the tumor stages and other specifics of the cancer in the patients that are included in this study. Sorry, I'm in a room without, just a second. Okay. So regarding the erectile function assessment, we should use validated tools such as the IIEF questionnaire. A lot of the studies that I already talked about used non-validated tools, and that can kind of contribute to heterogeneity in data. And the erectile recovery function has different definition. Some people define erectile function recovery as back to baseline, but some people suggest that we should define it more as patient satisfaction, because intercourse satisfaction may be lower even for those achieving baseline erectile function. And we should also report on timing as well as penile rehabilitation if possible. And finally, for the post-op assessment, we should include data on radiotherapy, chemotherapy, so basically other cancer treatments. We should include some data on urinary continence, because urinary continence is a significant predictive of erectile function recovery after radical prostatectomy or radical cystectomy. We should also report data on what kind of urinary diversion the patient had, and I'll talk about that a bit later, and also psychological factors that might be related. So when we think of sexual sparing techniques of radical cystectomy, there are four main techniques that have been reported in the literature. So the main one, the first one is the prostate sparing radical cystectomy, which basically, as the name implies, will retain part or the whole prostate, the seminal vesicles, vas deferens, and their neurovascular bundles. The functional outcomes that have been reported is that around 82% of men will recover sexual function post-op at some point. And I will talk about the oncological concerns that this technique might have later. There's the capsule sparing radical cystectomy, in which the prostatic capsule remains, and we do either a TURP or an adenectomy, preserving the capsule. And the seminal vesicles, vas, and neurovascular bundles are also preserved. Variable potency preservation rates that have been reported in the literature. Then there is the seminal sparing radical cystectomy, which, as the name implies, preserves the seminal vesicles, vas deferens, and neurovascular bundle. And basically, what the technique implies is a blunt anterior dissection between the posterior bladder wall and seminal vesicles up to the ejaculatory ducts, and a retrograde prostatectomy. Functional outcomes, about 95% of preserved erectile function. Maybe it's a high percentage, but that's what the literature reports. This technique, however, has some concern of urethral stricture, and the oncological risks are still unclear. And there is what I saw mostly in my residency, but the nerve-sparing radical cystectomy, which preserves the neurovascular bundle while excising the prostate, seminal vesicle, and the vas deferens, which leads to satisfactory erectile function without necessarily compromising the oncological outcomes. This is just a diagram showing which the kind of the extent of where we do the radical cystectomy, for each method. This study kind of looked, the graph is very confusing. I think they mixed up favors sparing to favors radical, but basically comparing the different types of radical cystectomy, the sexual sparing ones versus the non-sexual sparing ones. Here we're looking at oncological outcomes, which is important to keep in mind. But basically, when we look at local recurrence, there doesn't seem to be a difference between sexual sparing and non-sexual sparing in terms of local recurrence statistics. So the sexual sparing one had similar local recurrence as the control group. And when we look at metastatic recurrence, it was only reported in one study, but there doesn't seem to be a difference. If we look at comparing the different sexual sparing approaches, there doesn't seem to be a difference in outcome for all of them in most studies. If we look at sexual outcomes, again, this is kind of confusing, but the sexual preserving cystectomy showed better erectile function than the standard cystectomy. There is one study published by Colombo that said that there is possibly better outcomes for the capsule sparing or seminal sparing cystectomy over the just nerve sparing cystectomy. However, it's a small study that's retrospective. And so sexual preserving techniques offer generally better sexual outcomes than a standard radical cystectomy without a difference in oncological outcomes. There doesn't seem to be one technique that's clearly better than other sexual preserving function techniques. There is implementation challenges as these techniques have a steep learning curve. So not everyone is skilled to do them. And some recommendations, so these techniques should only be ideally offered for patients who are motivated, who have organ-confined disease and tumor-free bladder, neck, prostate, and prostatic urethra, and they should have some form of prostate cancer investigation before suggesting those treatments for patient. And I'll talk about that a bit later. This is basically another study showing the same thing. So the erectile function in patients who had nerve-sparing radical cystectomy seems to be better than patients who had non-nerve-sparing radical cystectomy with a significant relative risk of 9.35. And this is for the overall survival, which and the more of the oncological outcomes, which also didn't seem to differ between the two groups. So one study suggests some surgical indications for those patients. So patient selection, patients should have good pre-op erectile function and low disease burden. Ideally should be younger patients because usually they have better erectile functions and they tend to have better outcomes in terms of after these procedures. Ideally, patients who should have a T2 or lower with no evidence of disease at the bladder, neck, or urethral margin. And as I mentioned, they should have some form of prostate cancer investigation before, ideally a PSA less than 4, a normal DRE, and normal prostate imaging, whether that's a TRUST or an MRI. Interestingly, there is also some literature on the role of pelvic lymph node dissection on erectile function. So the inferior hypogastric plexus or pelvic plexus, as we know, controls a lot of the erectile function in men, including erection, ejaculation, and urinary continence. And it's located in this fibrous plane, which is between the bladder and the rectum. This is an older study, well, not that old, 2004, looking at 381 men who underwent radical cystoprostatectomy and the orthotopic bladder substitution for bladder cancer between 1985 and 2003. And basically what we're looking at here is patients who at the final pathology, so the dashed line is patients who had a positive node, and the other ones are patients who had negative nodes. And what at least on the univariate analysis, they concluded that there was the y-axis is erectile function, but better recovery of erectile function in men with negative lymph nodes compared to those who had positive lymph nodes. And they suggest that maybe aggressive dissection of the lymphatic and fatty tissue near the iliac vessels and obturator nerve in patients with suspected lymphatic disease can damage the pelvic plexus branches. Again, it's not clear if it's a confounder because those patients also have a higher burden of disease. There's a few studies. I just included here the conclusion by basically comparing open versus robotic approach for radical cystectomy and erectile function. And there doesn't seem to be an objectified difference in erectile function using open versus robotic. Theoretically, we could hypothesize that maybe there is a better visualization of those structures with a robotic approach, but it's not proven. Technical aspect, I included just this because I found it's interesting study. It's a small study, but still pretty interesting. They were comparing ligature versus the stapler when dividing the lateral pedicles of the bladder. So this was a prospective clinical trial of 113 male patients who were healthy, sexually active, less than 70, who didn't have radiotherapy. And basically, the sexual function was compared for both patients at 6 months and 1 year after surgery. And at 12 months, there seems to be a difference between patients who had dividing of the pedicles with ligature versus a stapling device. It was a small difference, but a statistically significant difference in the SHIM score. And this seemed to favor patients who had the stapler compared to the patients who had ligature. And at 12 months after radical cystectomy. And the authors hypothesized that it might be related to the thermal damage that ligature can do to the neurovascular bundle. If we look, I'm almost done with the cystectomy section, which is almost the end of the presentation. But if we look at reconstruction type or diversion type, most studies were done at the University of Michigan. So using the bladder cancer index questionnaire. And when we look at the sexual domain, patients who had, so basically patients who have their native bladder in place versus patients who had cystectomy, and then specifically in patients who had cystectomy, patients who had an ileoconduit versus a neobladder. Obviously, patients who have their bladder still in place seems to have better sexual function, and then patients who had a cystectomy. But there was no clear difference between an ileoconduit and a neobladder in that study. So sexual function seems to be the same whether patients had an ileoconduit or some kind of orthotopic diversion. This also a study at the University of Michigan, probably the same group. So patients they also used the bladder cancer index, and they included 139 patients who had neobladder, 85 conduit, and just a control group of cystoscopy patients. And they also concluded that it didn't seem to be a difference between the different types of diversion, so whether it was a continent, non-continent, orthotopic or not. But the only thing that was different is that sexual function appeared to worsen over time for patients who had a conduit, while it seems to improve over time for patients who had a neobladder. So there might be a small advantage to a neobladder. So it's just basically resuming what I said, but there seems to be maybe a selection bias in those studies because patients who underwent a neobladder are typically younger, healthier, and more engaged in recovery than other patients in general. So that might affect all quality of life outcomes, including sexual outcomes. A quick word on orgasmic dysfunction, but also to keep in mind in patients who had a radical pelvic surgery. So this study looked at all pelvic surgeries, so urology, colorectal, and vascular surgeries. If you look at specifically radical cystectomy, 62% of patients after cystectomy do not achieve orgasm post-op. And patients who have nerve-sparing surgery and some kind of urethral preservation have improved chances of maintaining orgasmic function. There is no really study reporting on painful orgasm after those surgeries. And the last thing I think that's important to keep in mind is climacturia, especially for patients who might have an orthotopic diversion after a radical cystectomy. It was found in 20% of patients, and it was lower in the patients who had cystoprostatectomy versus a radical prostatectomy, so more common in prostate cancer. Timing of onset is usually 12 months after surgery, and it seems to be related to possibly orgasmic pain and penile length loss. I'm just going to go quickly over this slide, but the studies on orgasmic dysfunction treatment are only for prostate cancer from what I've seen. But if we extrapolate to radical cystectomy and bladder cancer, might be a benefit to treating with PD-5 inhibitors. Very quickly on metastatic bladder cancer treatment. So the main, looking at immunotherapy, The main treatments that are known to have an effect are the immune checkpoint inhibitors. I haven't included all treatment for bladder cancer because it's very long, but pembrolizumab and nivolumab. So immune checkpoint inhibitors, particularly the PD-1 inhibitors, have been shown to cause both primary and secondary hypogonadism. So primary hypogonadism is direct damage of the testis. It will be associated with decreased testosterone and high FSH and LH. The evidence is there, but it's weak, and it's mostly in the form of case reports and case series. Suggested mechanisms include CD8 plus T cell activation and possibly oxidative stress, which will lead to testicular toxicity in a rat study. There's also some evidence that immune checkpoint inhibitors, including for bladder cancer, can cause secondary hypogonadism, so damage to the hypothalamus or more frequently the pituitary gland itself, which will lead to decreased testosterone and decreased FSH and LH. When we talk about treatment with immune checkpoint inhibitors, we often think about the hypothalamus and hypopituitarism, which are known side effects, but we don't think about the sexual side effect that these diseases can have on patients. So just here I've included all of the immune agents and the impact they can have on the hypophysitis. And also some impact on libido and sexual function for patients on immune checkpoint inhibitors. One study which reported some mild effect on erectile function. And potentially that is related to the disruption of the HPG axis in patients receiving those treatments. When we look at chemotherapy, there's no specific treatment on the effect of bladder cancer, chemotherapy specifically on erectile function. But there's studies on chemotherapy in general. So this is a study looking at the US FDA adverse event reporting system, followed by an in vivo study. In summary, the chemotherapy agents are mostly involved with erectile dysfunction are melphalan, vincristine, docetaxel, methotrexate, and doxorubicin. Relevant for for bladder cancer, we have doxorubicin, docetaxel, methotrexate, and ifosfamide, possibly in some patients. And this was confirmed in rat studies. And these suggested mechanisms of actions include for methotrexate, proven decreased libido, hormonal changes, and vascular changes. For cisplatin, some vascular changes as well as nerve damage, and for 5-FU, hormonal changes that have been associated with worse sexual function. And just a final word on psychological causes. So there is all the effect of the disease itself, the treatment, but just a diagnosis, especially in the peri-op period of patients with bladder cancer, may impact erectile and sexual function. There are concerns due to relate to recurrence and disease status, altered body image, especially in some urinary diversions. The stoma itself can cause stress, body image issues. Neobladder patients might have incontinence issues, poor urine control. And there is not much of a literature on that that I could find, at least. That's it. It's pretty late already, so I can go over key points, but it's basically just summarizing what I already said. So I don't know if someone had any comment or any question.